You could just go to from the beginning.
All right. Good evening. So it sounds like I'm the least experienced of the three of us, so I guess they decided to send the most junior person to go first. Hi, Bella. So I'm really excited to be here. Thanks for coming, and thank you all to the organizers for the invitation to be here. This is great. We're, what, 7 states, 7 sites?
Yes, 7 states, 6 sites.
6 sites, talking about building an inpatient code sepsis team, which we've been doing at Grady for the last year. I suspect that there are other hospitals and systems out there, especially at the satellite sites, who may already have a program like this in place. So I'll be really interested in the Q&A portion of this talk to compare and contrast what we're doing versus what others are doing, so that we can all learn from each other. We divided the talk into 3 parts with our 3 speakers, so I just wanted to sort of go through what each of us will be covering. In part 1, I'll talk about some of the evidence supporting timely identification and treatment of sepsis, and specifically talking about critical care bundles to drive improvements in care and outcomes. In part 2, Barbara will talk about key components of building an inpatient code sepsis team through our experience, and specifically within that topic, we'll talk about rapid response as the vehicle that we chose to try and drive and coordinate care. Thanks, Jamika. To the patient. And then a final, but last but not, of course not least, part of the talk, Sharika will talk about lessons learned from our experience and give a very compelling patient story from a sepsis survivor. In my part of the talk, I'm going to go through the why. So why did we choose to do this? Trying to improve compliance with sepsis care bundles, to drive improvements in outcomes, and then some of the details, just briefly at a high level, of the who, what, when, and where, of how we went about doing this. So first things first, why did we choose to try and build an inpatient code sepsis team? Well, as we all know, according to the 2016 new definition of sepsis, it is acute, it's life-threatening, it's organ dysfunction, it's caused by a dysregulated host response to infection. And one of the operative words in the definition, of course, is life-threatening, right? So this is something we all tackle every day, knowing the mortality rates associated with this deadly syndrome. Such that many argue that sepsis is the 3rd most common cause of death in our country. Many people believe that. Some have tried to show that using some composite data from national census information. You can put that together and make a case that that may be true. That amounts to 1 patient dying in our country every 2 minutes from sepsis, contributing to up to half of hospital deaths. And it also is the most expensive reason for hospitalization in the U.S. We also know that sepsis is everywhere. This is a study that was done about 5 years ago now by Chris Seymour and others out of King County, Seattle, Washington, and he was looking at a 10-year estimate of sepsis incidents in patients who were brought to the hospital by EMS. So this is EMS arrivals to the emergency room, and looked at the incidence of severe sepsis as compared to other life-threatening, time-sensitive conditions that have a very high level of public awareness, like heart attack and stroke. So that's in the pink and the gray. But as compared to those life-threatening, time-sensitive conditions, sepsis is much more common. So again, impressing the need upon all of us to tackle this as aggressively as we can. So that's the problem. What can we do about it? What is we, as hospital systems, what can we do about it? The Surviving Sepsis campaign in the 2016 guidelines is recommending that we all try to improve care for patients by developing systems that identify patients early in the hospital and also facilitate the implementation of the core components of care through the 3- and 6-hour bundles. Of the elements in the bundles, we all know that early antibiotics is of paramount importance. So I can't help but include this slide from a landmark study from Kumar and others from over 10 years ago now. And this was a very elegant study of patients with septic shock in about 5 different centers, looking at about 2,000 patients with septic shock. And he wanted to evaluate the association between the time it took to get antibiotics into the patients and the association with hospital survival. So as you can see on the x-axis, the time it took from the onset of hypotension and shock to the time the antibiotic got into the patient, there's an almost linear association in the chance that she would survive her hospitalization. And that chance goes down dramatically as time goes by, which is why we are always trying to drive improvements in the time to antibiotics in our patients with sepsis. The last 2 studies I'll show you about are really structured to try and answer the question of whether improving sepsis care means that we should improve compliance with surviving sepsis campaign bundles to improve outcomes. This study by Mitch Levy and others is, to my knowledge, the largest published study of QI improvements around surviving sepsis campaign bundle care to date. It was a global study that lasted over 7 years, and they really wanted to evaluate the effect of surviving sepsis bundles on mortality. And they engaged 218 hospital sites on 3 different continents, enrolled almost 30,000 patients with severe sepsis or septic shock based on the first consensus criteria definitions. Patients were in one of 3 different care settings: the emergency room, med-surg areas, or the ICU. They looked at all of these patients in compliance with bundled care and evaluated the association between outcomes with that care. In short, the results were pretty striking. So these are 3 different graphs, and let's start here. So any site could be enrolled in the study for up to 16 quarters. So we have time on the x-axis, and it looked at compliance with the 2 different bundles that were in place at the time. So these are different bundles than we use today. This is a 6-hour resuscitation bundle and a 24-hour management bundle. But as you can see, the longer that you participated in this campaign, in this improvement initiative, the higher your compliance with the initial resuscitation bundle, which we'll get into the details of in the next slide. And the same with the management bundle. Over 24 hours, the longer that you participated in the improvement study, the better your compliance was. The kicker is the last graph, which is the effect that compliance potentially had on mortality. This was, it's not a randomized controlled trial, so we can't infer causation, but the association is very strong in that the longer that these sites were enrolled in the improvement study, the lower the mortality over time. Overall, they showed that in sites that were highly compliant with the care bundles, and that cut point was if you were more than 15% compliant as the baseline, which I don't know that any of us would say that's highly compliant, just at sort of a knee-jerk reaction response, but that was their threshold because that was the median compliance when they started the study. But 29% compliant, or 29% mortality in sites that were highly compliant with bundled care, as compared to sites that were less compliant with bundled care, where mortality was 10% higher to 39%. So a striking difference in mortality. They also described what they termed a dose effect. So the longer that you were participating in the study, the lower your mortality, such that for every quarter that you remained in the study, the mortality for your patients at that site decreased by 0.7%. And finally, they described an association with length of stay. So for every 10% increase in compliance that you could give with bundled care, length of stay for those septic patients decreased by 4%. So pretty robust data from many different sites, thousands of patients, indicating that if we all are striving to provide bundled care that is based on evidence-based medicine, that our patients more than likely will do better. This is the last study I'll show you. And I'm being mindful of time, so we've got 5 minutes left. This is the IMPRESS study. So this is more recent. This is also looking at the association between compliance with bundled care and outcomes. But in contrast to the prior study, which was longitudinal over a 7-year period, this is a cross-sectional point prevalence study. So they did this in 1,700 patients from 62 countries, 6 continents, and the study took place on November 3rd, 2013. So again, they looked on that date at all of these hospital sites and patients to determine compliance with bundled care and outcomes. So a different study design, but also looked at the same set of patients. So severe sepsis and septic shock patients based on the original consensus criteria definition. These patients were enrolled from either the emergency room or the intensive care unit. And instead of looking at the 6 and 24-hour bundles that were part of previous guidelines, this study looked at our more recent 3 and 6-hour bundles, although I will say that the 6-hour bundle was the version 1 of our step 1 core measure criteria. So it's been modified. You'll see that in the next couple slides. So these were the results about 3-hour bundle compliance. The first part of this graph shows the 4 elements of the 3-hour bundle. So these are the things that we ideally would be doing for every septic patient that we encounter. We would get a lactate, we would get blood cultures before antibiotics, we would get give the patient broad spectrum IV antibiotics, and we would give them a fluid bolus. These are things that we're all familiar with. And you can see individually that about half of patients got any one of these bundle elements. But taken together as a full bundle of care, only 19% or less than 1 in 5 received all of those elements. So they looked at full bundle compliance versus mortality and showed again that those who were compliant with bundle care had a 20% in hospital mortality as compared to missing one or more of these elements, which was associated with a mortality of 31%. So again, pretty striking data, 6 continents, thousands of patients. Although it's not randomized, it's compelling. Same thing with 6-hour bundle care. So again, this is what will look different to some of us because this is not the entirety of our current 6-hour bundle, but the first 2 components are the same. So in 6-hour care, we strive to obtain another lactate in those who had an elevated lactate to begin with. We apply vasopressors for patients who are persistently hypotensive after a fluid challenge. And we reassess their volume status, and in this study, the only metrics for that were central venous oxygen saturation and the central venous pressure. Again, for any one of these elements, over half of patients received at least one of those, but together as a bundle, only a third received the full package. And again, they looked at this compared to mortality in the hospital and found the same association, that for those who received full bundle care, 22% mortality as compared to those who missed one of these marks or more, 32% mortality. So again, trying to make the case to everyone, which hopefully this is a sort of a don't preach to the choir scenario where we all are in agreement that this type of care will improve outcomes for our patients, but just wanted to show you some of the evidence on that. The final analysis they did for this study was looking at some multivariable logistic regression modeling to estimate the association with mortality a bit in a different way. So again, here showing that the odds of dying in the hospital are almost 40% lower in patients who receive full bundle care. So that's the takeaway, is that the evidence that we have supports that this is how we should be caring for our patients at a bare minimum. So that leads us to what we've done in the past year at Grady in trying to improve our sepsis identification in our inpatient environment through the code sepsis mechanism. So we decided on this mechanism because we felt it would be a tool to identify high-risk patients quickly and allow us to intervene as a coordinated team without delay to improve care and outcomes. This is sort of a roadmap of how we went about launching this initiative. Each one of these bullets is probably a talk in and of itself. And since I have 1 or 2 minutes left, I won't be able to do that, but just to go through it at a high level, the order in which we proceeded was to engage multidisciplinary, multi-professional representation on our code sepsis planning team and our sepsis committee. We engaged key stakeholders from all areas of care and anyone who would touch a patient with sepsis in the hospital and who would touch this process. We have a very supportive hospital leadership team that has supported a sepsis coordinator for our efforts, and Sharika makes things go every day, so without her, this would not have happened. We identified champions for sepsis care in all different care areas. We developed guidelines, so we wrote down what we wanted to do to give others a roadmap for how to proceed, and that's the page on the right. We set some goals around what we were doing. We devised protocols so that we could educate around those. We developed order sets. We're on Epic here at Grady, so we developed very bare bones and lean order sets to try and drive improvements in care toward these goals. We developed standardized documentation for 3- and 6-hour care for both providers, rapid response, nursing, all the people who touch the code sepsis process. And at this point, we're still working on this, but are also incorporating standardized metrics, the reporting structure to be able to analyze what we've done, whether it's helping patients or not, and then allowing us to give feedback and educate it as an ongoing process. This is the code sepsis team, so I thought it would be important for you to see who comes to the bedside when a code sepsis is activated in our inpatient environment. So again, the vehicle and the primary driver of early care is rapid response, our nurses who are on call 24/7. The provider for the patient is also notified that a code sepsis has been activated on their patient. The bedside nurse is the person who does that. Phlebotomist comes to the bedside to facilitate early sepsis labs, including blood cultures and antibiotics. Pharmacy is present as a Wizard of Oz phenomenon, sort of behind the curtain. So Epic will page the inpatient pharmacist when any sepsis antibiotic order is signed to notify them that they'll need to verify that order and make sure that it gets into the patient within an hour. And also respiratory care therapy to manage advanced airway issues, oxygen, other labs, EEGs, etc. Our sepsis alert criteria is hardwired into our electronic health record. These are our criteria as a sort of modified SIRS and QSOFA criteria, and if any 2 or more of these are present and there are a change from the patient's baseline, that will trigger an alert to either the tech who obtained the vitals or the bedside nurse who obtained the vitals to evaluate the patient immediately and proceed as indicated. There's an extra walkie-talkie up there, so that'll come into play a little bit later, but I just wanted to walk you through our process here. So as vital signs are obtained, we did this in 2 pilot units. On any patient, they're entered into the computer, and if they meet the alert criteria, an alert is fired to the person who obtained the vital signs to immediately either notify the nurse or go to the bedside to evaluate the patient. If the patient meets criteria on that initial assessment, the nurse calls the inpatient 911 operator to activate the code sepsis. Communications then deploys the mass communication to the code sepsis team, all of whom are expected to arrive at the bedside within 15 minutes. Sort of treating this similarly to how we treat a medical code. At the bedside, the goals are to 1, evaluate the patient as a team, 2, facilitate discussion amongst the team about who needs to do what in what time frame so that we can deliver good care to the patient, and also to get those things done. So within 1 hour, the expectation is that we will have completed the 3-hour bundle elements. There's standardized documentation that goes along with that so that we can see, anyone can see that care has been delivered. And then there's a reassessment piece over a period of time. Everyone comes back to the bedside to reevaluate the patient to see whether the patient is improved from initial therapy or whether or not a higher level of care and more aggressive therapy is needed. So we went live with this pilot just over 2 months ago. Again, 2 pilot units, 1 med surge, 1 step down. In line with what we've done as a sepsis committee, our CNO at Grady has also piloted nurse performance improvement initiative throughout the hospital in different care areas and different disease processes. But one project that they're working on is to improve screening for sepsis from the nurse's perspective. And with that initiative, they've been able to improve sepsis screening compliance to over 90% in these 2 pilot units, which has been amazing. To date, we've had, and this is a little bit dated data, but as of this slide date, there were 19 activations that had occurred in 2 months in those 2 pilot units. In about 20% of those cases, the rapid response order set had been activated. In over 60% of cases, the physician order set had been activated. And in over 40% of cases, the physician documentation had been completed. So again, we're still trying to build our automated reports to have more clarity about what's going on within this process so we can continue to improve. But to me, these are encouraging data. They're maybe not where we would ideally want them to be in our desired state, but they're a good first start. So next steps are to optimize our process, to optimize our reporting, to continue education, build this into some of our annual mandatory training within the hospital for medical staff, nurses, etc., to do case reviews and standardized methodology that we use to report out and target feedback to different individuals and go from there. So with that, this is our team. Big team, a very passionate team, lots of discussion in our meetings, which makes for a very rich conversation. So just a thanks to everyone in this room and outside of this room who has participated. So with that, I'll hand it over to our team.
Thank you. So I'm not answering my phone. I'm just putting a timer on because I could listen to Carmen all day long, and she's covered a lot of what I'm going to say. Hi, everyone. I'm Barbara McLean. I'm a clinical nurse specialist for critical care here at Grady, and I know a lot of you from other areas and from other work that we've done together. My idea would be to really look at our foundations and have some good strategic information, but I do want to just mention one thing. 19 activations, but actually, when rapid response arrives, many of those patients actually didn't have sepsis. So that is one reason of explanation why you see a lower level of the RRT sepsis order set use, because there may not have been agreement that the patient had sepsis. And then I think the 63% of the physicians is based on those patients who actually have sepsis, because if they're not actually agreeing that there is sepsis, the order sets may not be used. So I think that might be a little variable in our data, but I'm not certain. I don't know that answer for sure. So I do think it's important for us to say that we know, that we absolutely know that, as Dr. Polito shared with us, that patients who receive bundled care actually have a much higher, at least from these evaluation studies, a much higher survival rate. There will be in the fall a release of a publication that is managed by the leader of a tele-ICU that actually is gathering data from around the United States, 2 million points of data that are going to show very significant correlations. I don't know what the data is going to show yet, but I think we're all looking forward to that. We do know that for every single patient that is treated in a timely manner with appropriate bundled care, 1 life out of 7, that's the number needed to treat, 1 life out of 7 can be saved. Now that may not seem like a large percentage to you, but if we look at bundled application of care and how we instrument that, we can save 1 life for every 7 patients that we see. So our idea was to actually implement strategies that, first of all, helped us to identify all patients at risk who are inpatients, and that's primarily what we're talking about here, and then immediate notification after identification. And that was a big bridge for us. That's a difficult component. And then timely intervention. So identification, notification, and intervention, which really are the theoretic underpinnings of what we try to do here at Grady. So first and foremost, I want to address something that I think is always on everybody's mind, and we always have a lot of discussion about it, which is informing our colleagues if they already knew SIRS, sepsis, severe sepsis, and septic shock, informing our colleagues of the change in the overall perspective of identification information. So for those of us interested in sepsis, which I'm assuming everyone is, we know that from SIRS to septic shock on the continuum, with the sepsis 3 information, we changed the definition. But it's really important to appreciate that the definition actually hasn't changed. What's changed is that notification, alerts, and alarms were occurring so frequently based on simple SIRS criteria that the goal was to try to strategize to have a more effective methodology for identifying patients who were at risk without causing severe and profound alarm and alert fatigue. But it does actually end up being a point of contention. It's a point of contention in discussion. It's a point of contention in terms of evaluation of patients. I basically say just don't sweat the small stuff. If someone in your field is saying, well, they meet SIRS criteria, so I think we should treat them, okay, don't sweat the small stuff. We're going to evaluate that patient. We look to see if we can actually ascertain that there's evidence of infection. We're not going to be able to do that in a large part of the time. The idea for us today, though, is to move forward with a diagnostic panel that is actually going to reveal what we cannot see. And that would be the ongoing inflammatory process that actually is going to present itself in the laboratory analysis. So this beautiful study by Carmen actually looked at 100,000 patients with severe sepsis and stratified them by SIRS criteria. And it was remarkable when looking at this analysis that 12% of patients who actually had severe sepsis met only 0 or 1 of the SIRS criteria. Now, that's quite amazing to most of us because we think about SIRS criteria as being very sensitive but not specific. And in this case, they're not even sensitive for these patients. And that's in particular for those of us in hospital, and particularly in hospitals like Atlanta Medical Center and Grady Hospital, where we see patients with significant comorbidities, patients who are receiving beta block therapy and other management strategies that actually limit their basic ability to manifest SIRS criteria. So when, again, looking at this study, same study said, is there anything special about meeting 2 SIRS criteria related to the cutoff? And indeed, that is important because that actually is highly linked to mortality. So as Dr. Polito said, in 2016, the new guidelines from the Society of Critical Care Medicine and the European Society of Intensive Care Medicine and the Sepsis Alliance and the Sepsis Organizations, the Surviving Sepsis Campaign, gave us the new definition, getting rid of the word SIRS and severe sepsis, and now looking at sepsis and septic shock. And the major definition in sepsis is you do meet SIRS criteria, we're still using SIRS criteria, and some indication of organ dysfunction in the presence of a known or assumed infection. Okay, it's pretty straightforward and not that big of a change. Septic shock is defined as refractory hypotension, meaning mean arterial pressure less than or equal to 65 millimeters of mercury, and that's really important, and or a lactate greater than or equal to 2 millimoles. So when we're evaluating our patients and when we're looking at that information, this becomes so incredibly important. It's what defines, after fluid resuscitation, is what defines a patient that we're going to call septic shock. And this is quite important for us as providers. It's really important in terms of how we built this in to the structure of building foundations to help us evaluate patients, because it's vitally important to remember. You suspect sepsis, but in today's world, you cannot say a patient is septic till you have proof of organ dysfunction. So that's really critically important. This is a big change from where we were before. So that, I think, is really vital for us to consider. So now we talk about, well, you're looking at organ dysfunction. How do we quantify organ dysfunction? So we've actually embraced, worldwide, we've embraced criteria that have been used in Europe for at least 20 years, and that's called sequential organ failure assessment, or the SOFA score. Now, SOFA score is somewhat intricate. So in order for us to apply this in a general fashion, in the medical surgical areas, in any inpatient outside of the ICU, we're going to use something called quicksilver. Quicksilver actually gives you a sign of organ dysfunction that you're measuring based on level of consciousness, and that's all. It's simple. So you have 2 SIRS criteria, and they're particular. I'll show that to you later, and a change or an altered level of consciousness. So I think as providers, one thing we want to think about, and as we go forward, we think about how it is that we've determined someone has an altered level of consciousness, because Glasgow Coma Scale is not good enough. And so we're going to have to think about how we're growing our evaluation and how we're recruiting and understanding that we have patients with sepsis. So again, I think always really important for us to always take all evidence and research with a grain of salt as we build our methodologies. So first and foremost, educating and implementing the change. So I'm going to remind us all that the #1 problem in sepsis management is failure to identify. We know that if we can identify patients early, we can move forward with better resuscitation and intervention. However, we also recognize that patients get identified, but they don't get treated. And treatment is not necessarily a subjective component. Treatment, when patients meet criteria for sepsis, we must consider that it's important for us to move quickly, to actually resuscitate patients quickly, because what we're really trying to do with the antibiotic is to stop the inflammatory cascade, and with the fluid to actually achieve better perfusion. And those 2 things have to happen fast. We don't have 6 hours or 8 hours or 10 hours to wait. We can't wait with an antibiotic that comes up on Pyxis and is on a 12-4-8 schedule, and it is 12:30. So that patient won't get his antibiotics until 4. We're not able to do that when we're talking about sepsis. These are stacked drugs. They must be administered immediately. The other component is, even if we resuscitate quickly, that we have failure to reevaluate patients. And there's a lot of complexity to these 3. Every single person in this room has actually participated, I'm sure, in some complexity in terms of identification, communication, and intervention. And particularly when we work in institutions where we have a lot of variability in our staff, where we have a lot of variability in our physicians, it becomes much more difficult to stabilize and maintain a protocolized approach. Even the best protocol requires continuous education, reaffirmation, quality, data, regulation, and evaluation. So intricate and complex. And nothing is as simple as a simple algorithm. But you start with a simple algorithm. That's where you start. And then you have somebody great like Sharika who's gathering all the data and evaluating it. So the very first thing that we talked about is identification is key. We want bedside identification to occur real time and be documented right now and to be communicated immediately. Identification is essential. But the first identification can be done by anyone who can do a set of vital signs. Then that becomes reevaluated by someone who is actually confirming abnormals and actually looking at whether there's a possibility for infection and who actually does a sepsis assessment. So we decided to put into play a 2-step approach at the bedside. We know that rapid evaluation and intervention saves lives. It's been well evidence-based, although we have not had prospective trials looking at the difference because we would have to withhold care. We're not going to be able to do that. And that, of course, is the problem for those of you who know about PROMISE and PROWESS and ARISE trials. The problem is those patients already got resuscitated when they got enrolled. There's no comparative analysis to take that against early goal-directed therapy from many rivers. Now, I want to say thank you to the Division of Education, particularly Dr. Harris, and two of her clinical educators and clinical nurse specialists, which, by the way, I'm a clinical nurse specialist. They have done a fabulous job integrating and improving this methodology and implementing educational strategies in the first 2 units that we piloted, and there's many others as well. And then I want to remind you that most of this is about educate, 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 modify, educate, 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 modify, and you have to be flexible, you have to be fluid, because what works may not, what you put into play may not work. and you learn from that and then change the plan. So I think what we certainly recognized as a major barrier to sepsis identification is human factor. We don't have enough staff. We have very high acuity patients. We wanted to remind ourselves that we want to empower anyone who's at the bedside to be able to have a basic identification, but not have to think about it. All they have to do is do the vital signs and put it into our electronic health record immediately, because we can automate it. And what we've done with automation is we actually fire an alert. So what our first step in our protocol says that the person at the bedside is doing vital signs, so depending on where you are, this is not for the ICU, this is outside of ICU, where you are, you most likely here at Grady will have a patient care tech or a nurse tech or a CNA who's doing your vital signs. So those vital signs are checked now at our request. Is 8 a.m. and 8 p.m. or any time vital signs are performed acutely because the patient is vomiting or is complaining or is dizzy, and they have to be documented real time right now in Epic. And if that patient actually meets 2 or more abnormal vital sign criteria, we will have a sepsis BPA fired. Thank you, Epic, and thank you to our Epic team who've been so important. Now that right now, that real-time documentation, if that meets the criteria, our Epic alert or BPA fires, and that requires a right now notification to the nurse. So the PCT put the data in, now they get an alert, they have to get a nurse. That nurse has to see the patient within 15 minutes of the notification. So we're able to track all this as long as everyone is putting in their data. And of course, we're using basic vital sign criteria, very similar to the SIRS criteria, in fact, exactly the SIRS clinical criteria. Heart rate, respiratory rate, temperature, and oxygen saturation. And then, of course, systolic blood pressure. Sorry, I should have said respiratory rate is not separated here, but it is actually separate. So you may not have a pulse ox capability, depending on where you are in the hospital, so you're going to use your respiratory rate. And this is our basic first sepsis alert. PCT, notify nurse immediately. They get a hard stop when they put in their data, and it says, immediately notify the nurse. So the PCT now can't do all the rest of their vitals. They have to go tell the nurse that they've had a sepsis BPA alert fired. That bedside nurse now will come to the patient. This is our second level response. The nurse will repeat and confirm the vital sign abnormality whenever sepsis alert criteria were met, and only the nurse responds to that second alert. PCT can't respond to that, the bedside nurse responds. And they utilize and document on their sepsis assessment flow sheet, which actually comes up when they go back to do the next set of vital signs. So now they're going to utilize and document a sepsis assessment flow sheet, and this is, I don't have the flow sheet here, but it's the basic that this is an acute change, that this is different than it's been before, and that's it. We're not asking the bedside nurse to say, oh, I think it could be an infection. Do you have a mental status change? What's your glucose? We're not asking that. We're saying, is this an acute change from normal? Is this the patient's chronic vital signs? Is there an acute change? And if there's an acute change, the next thing that's going to happen, immediate notification of identification. And that criteria tells them that they call a code sepsis. So we have an in-hospital 911. We have to be really careful about this because we really have to always educate everyone. We've been using in-hospital 911 for quite a time. We use in-hospital 911 to identify to the operator that we have an emergency. We have it for chest pain, we have it for stroke, we have it for trauma, and now we have it for sepsis. So when that nurse calls the operator, 911, not an outside 911, inside 911, the operator sends out a text to everyone who is on the sepsis activation team. That's really important. So we think about how to build a village. You can see we have an epic build, we have the bedside vital signs, we have the bedside nurse, we have the 911 operator who sends out a signal. That includes rapid response, phlebotomy, respiratory therapy. We notify pharmacy, but pharmacy is not coming to the bedside. They're waiting to see about the antibiotic orders. And the nurse will actually call the physician because our physicians change all the time. We don't have one particular physician. And then we think about how we involve bed management and how we involve quality. bed management is not getting notified of a code sepsis, but bed management has to be involved in this so that we can be sure that we can get some beds. So rapid response is where this rubber meets the road. And this has been, I want to make sure, especially because I have some wonderful members of the rapid response here, I want to be sure you appreciate, this was not easy. Within a culture that is a teaching culture for physicians, it wasn't easy to actually say, nurses from the rapid response team are empowered to come to that bedside, order a diagnostic panel, and initiate a fluid challenge for patients who meet criteria. But that is what happens. So rapid response comes to the bedside, they evaluate and confirm the vital signs. They don't even have to say all the vital signs are abnormal. If they believe there's the possibility of infection, they're going to move forward. And they look at whether or not there's acute changes in mental status. And of course, that requires communication. The answer is yes, they're going to intervene right away. 500 mLs of lactate ringers as fast as possible. Do not be giving people 999 on a pump, too slow. 5 minutes. 500 cc's, 5 minutes. So they now carry pressure bags. It's like a sepsis response bag. They carry their pressure bag. And then they also guide phlebotomy on the drawing up all labs on the sepsis protocol. So this is a basic Q-SOFA. It's just respiratory rate greater than 22, altered mentation using a Glasgow Coma scale, and a systolic blood pressure less than 100. Having 2 of those criteria means you meet criteria for sepsis. So rapid response is where the rubber meets the road. Rapid response has had lots of education. We're going to continue their education. We're putting tools into their hands that are actually going to enable them to look at volume responsiveness, and we're not taking anything away from physicians. Physician arrives and the physician makes a choice. If they believe sepsis is validated, we go on to continue fluids to 30 mLs per kg as fast as possible through a pressure bag, and we try to do that within 15 minutes. And if you have known heart failure or end-stage renal disease and you're septic, we're going to slow it down to 30 minutes. You are still going to get volume, you're still going to get it fast, and the physician still has the ultimate decision-making capability. So this is our sepsis order set for rapid response. And then I just want to remind you that building a village means that you incorporate everyone. So real-time vital signs measured and documented in the BPA fires. That helped, the people who really helped us with this is EPIC. And then the nurse only, the bedside nurse, who right now has to confirm those abnormal signs, do a sepsis assessment, initiate a code sepsis, and call the primary doctor. And that requires very aggressive education at the bedside. And then our sepsis team. And our sepsis team, our requirements are you have to arrive within 15 minutes of code sepsis, and that includes rapid response, respiratory phlebotomy, pharmacy notified, but they don't come to the bedside. The MD arrives, confirms, or discontinues. So rapid is already doing the therapeutic interventions, that's really important, and documenting in their appropriate manner. And of course, we need leadership to help us with this and to continue giving us support. So again, PCTs identify and notify. Bedside nurse confirms and notifies. Sepsis team intervenes before diagnosis, intervenes, diagnoses, and then treatment. And it's all about, of course, the patient. So you know why we care. Here's some of our fabulous, fabulous rapid response team. I don't have everyone's picture, but I grabbed them every time I was doing education. I am very fortunate that I've been working with rapid response to educate them. And you might recognize that's me, and a big component of the team. And we have a lot of really excited people that really want to do the right thing and work together. You've got to create a team. Nobody can do this on their own. And when you implement protocols, you really have to hold people's toes to the bar. You've got to follow the protocol. You have to document. You have to utilize these tools. Certainly, you can make a decision that a patient doesn't have sepsis, but it's got to be documented. Why didn't we agree that the patient has sepsis? We need to know. And remember that we are going to revise, 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 and educate, educate, educate. I don't know if I've said that enough, probably have. So we have a lot more work to do. We're grateful because we can do data mining and database evaluation. We can come back and make changes. We're doing audits, and we're going to continue to do sepsis education and awareness because we want to continue to reinforce the team that we've built. Remember the 3 goals: identify your patient at risk, immediate notification, for us that's with the code sepsis, and to the primary doctor, and then timely intervention. And I mean timely. It has to happen fast. We give our fluids within 30 minutes with a pressure bag. We give antibiotics at 60 minutes, whether or not you've had cultures. Our goal is to have cultures. That's why we've embraced phlebotomy, and our lab has been doing a great job. We're not drawing the cultures, lab draws the cultures. And they do 2 different peripheral sites, no central sites. But it's important to remember, fluid and antibiotics regardless of cultures. We do lactate, we do cultures, we do chemical profile, we do coagulation, but we're always going to remind ourselves that the only way we can save a life here is with the village. That's what we're doing. We're building a village and improving communication between all of our groups in order to save the lives of patients every day. And it is a journey. And we might have a few houses fall down in the process, but we're going to continue to build, and we're going to continue to rebuild and reinforce. Thank you very much.
Okay, hello, I'm Sharika Kimbrough. I'm the sepsis coordinator that they've been speaking of, and they've covered a lot of what I've learned in my slides because they've been with me the entire time. So we all work together very closely. A few of the lessons learned that we are planning to discuss is just how to lay your foundation, how to customize it to your institution, since we know we're talking to multiple institutions. We want to talk a little bit about the electronic medical record. I know they made reference to that a lot, and the importance of communication and education. So again, it's going to be a lot of the same stuff, just a different way to deliver it. The first slide just says, take the time to lay your foundation. And I put that little brick and mortar because that's what it felt like in the beginning. I mean, it was very, very slow because we had a lot of discussion. But we took the time to do a literature review. We asked around to see what other centers were doing, and we wanted to find out what worked and what didn't. So again, we just didn't want to reinvent the wheel. We took the time to talk to all of our stakeholders. That's EMS, our emergency department, our inpatient unit, critical care. We talked to everyone and we got them engaged and involved in the process. And then we created our masterpiece. And I know Carmen already showed you that. Basically, it was our guidelines. And we came up with a general set of universal guidelines that we wanted every sepsis patient to have. And then we allow each area to break it out for themselves. Like, so the ED, operationally is a little different from ICU. So they have opportunity to take those universal guidelines and make them their own. So they're all part of that big protocol that we created. And then the other thing was roll out slowly and then scale up. Just like Barbara said, you learn as you go, and then you make it better. So if you roll it out to the whole institution, it's going to be a little bit hard to manage. So from our perspective, or from my perspective, it was better to start out slow. And we kind of, like I said, rolling it up a little at a time. Don't reinvent the wheel, customize it. Again, there's a lot of people already doing this. It's a lot of information. I use the Society of Critical Care Medicine to guide me. Yours, y'all have podcasts. I have a sepsis app on my phone. I listen to YouTube, and I go to all these different sites to get information and to get updates. So that's IHI, the Sepsis Alliance. There are just resources everywhere that you can use to get this information. So use your resources is my advice to you if you're starting a new program. And this is the slide about IT. Again, we did some phenomenal things with our EPIC partners, but if you have a different electronic medical record, I can't stress enough their value in how we collect our data, how we input our data, how we take care of patients. I mean, they did order sets. They did 4 sets of order sets for us. They did a RN-RRT order set, which the rapid response team can initiate, and that's the one that Barbara just spoke of. They did a 3-hour inpatient order set, just for the 3-hour patient. They did a 6-hour order set. And then we have a different one for the ED. They also did flow sheets for RNs and RRT. And those flow sheets feed into the doc phrases and they feed into other reporting mechanisms that we have in place. So we're excited about having all these flow sheets and doc phrases to help us be compliant with our core measure standards. And we made sure we had a core measure specialist at the table when we were making these decisions. And I think it's going to pay off very well for us. As far as reporting, we had an Epic builder who built a dashboard for me where I can see all the BPAs. She spoke of the BPAs. Those are the best practice alerts that pop up when the patient meets criteria to make it less human and more automated. She spoke of that, Barbara did, and so I can see the best practice alerts and why they snoozed it. I mean, to that granularity. So we, like I said, we have an amazing Epic team, and they've been working with us, and I'm really excited about the level of review that I can do and the amount of feedback that I can provide based on what they built for me. I've learned a lot about reporting in this role, but what else? They also, we can look at our sepsis assessments. We require that our nurses do a sepsis assessment on every patient, every shift. So I can see from my chair, you know, if they're doing it or not, and which wards was compliant, and which patients didn't have one in the last 24 hours. So I love that piece. And I can also see who's using our order sets and who's activating and what happened with those activations. So reporting is very, very important, just like the best practice alerts. They are very helpful to us, and hopefully at some point we will be able to analyze more data. And we are definitely working on that. Communication, like I said, is very important. You saw some of our team. That's not all of our team. We have a team of like 84 people. So they don't come to every meeting, but they are there a lot to support us, to give their input, and they're just there to get the information. So I early on built an email list that we use to communicate with all of our stakeholders and shareholders about what we're doing. We also use sepsis champions, like Dr. Polito said, and we're looking to integrate them a little more. We have a levels program here, and we're looking to make them where they can get points for helping us, like with some PI initiatives and being a little bit more hands-on. So we're working with nursing, critical care nursing, and the inpatient nursing staff to do that. And we also have a SharePoint where we can put all our minutes, all of our presentations, anything, we can just share everything there so that anyone on the committee who wants to use that information, they can, and they need to recall something, they can. So I just posted all there. We have standardized feedback. We give feedback on performance, and we also give a little feedback on process. So when there's an activation, we'll let them know, you know, you got there in 5 minutes, but you know, it took you 19 minutes to give the antibiotic, so we're able to give them feedback, and we're making that more and more standardized as we go. And we also have newsletter updates. So marketing, we work very closely with marketing. We have a contact over there, so if we have an update that we need to put out, they're doing work with us. Education is key. She already talked about that. We built a CBL module that everyone can use, and we just customized like the questions at the end for each user group. And so I felt like that was very efficient and a very efficient way to do it. Just make it a general CBL that covers everything, so we're all on the same page as it relates to sepsis and how we care for the septic patient. We created badge cards. We have tip sheets. We go out and do awareness. We had 2 MD showcases where our physicians came out to talk. We did Patient Safety Week. Like I said, we have a close relationship with marketing. If we need, you know, badge cards, tip sheets, laminated, copy, they help us with that. And then we have a multidisciplinary team where they can speak out in huddles, at staff meetings and in services. This is mostly like our champions and our unit educators who help us with this. Right before we had our, before we went live, we did mocks. And we plan to do mocks every time we roll out because we learned a lot about the process during that phase. And you know, it kind of helps us to check our education and how it went and to make sure the staff is ready for what's to come. So this is just a few of our staff members going through a code mock process. We use the simulator. I forget his name, but we use the simulator and it's fun. How? Yeah, we use how. And this is the last slide. There is a patient story embedded in this. I don't know if we have time for it. Do we have time for it? It's like, we should turn the volume down. We have a patient story. I went to IHI back in December and they talked about the use of patient stories. So this patient was not a Grady patient. She went to another local hospital, but she is a Grady employee. So we talked to marketing once again, and they allowed us to use her voice. So we're just going to share this sepsis story, and we use it with our awareness campaign.
Oh, yeah. I just haven't clicked it yet because you were still talking.
After 4 days of laying on the beach, fun in the sun, having a great time, something went terribly wrong. I started feeling really badly and had a mild hysteria. And I didn't really know what was happening. One thing I knew for sure is I did not want to go to a health clinic on the island because I wanted to enjoy the rest of my vacation. So I decided I would go to urgent care tomorrow on my way or when I get back to Atlanta. So when I wake up that day on my way to go back to Atlanta, I could barely make it. I could barely pack. I could barely make it through the whole process of checking out of the hotel, making it through the airport. I was weak and I was sick and I did not know what was going on. So I wanted to make sure I've gotten here on the island because we could not get through this process fast enough to get me back to Atlanta. But thankfully my friends were there to assist and God was sweet to me and provided my needs. So they go get me a wheelchair when we land because I can't walk off the plane. We have to go to customs and the whole thing. And I could not figure out what was going on because just 2-3 days ago, I was walking 25,000 steps and swimming in the ocean and doing water aerobics and having a great time. So I didn't know what I had done. Did I eat something? While I was freezing and aching and just didn't know what was happening. So I had two options, go to ER or go to urgent care. I did not want to go to ER because on Monday, ER wait times are ridiculous, and I did not feel well. So I decided I would go to urgent care. That would be the best for me, so I thought. And they would give me some medication, I could go home and I could go to bed. That's what I was doing so my time. So that's what took me to urgent care. I get there, I'm still sick, I'm leaning over because I'm weak. And I'm freezing rather than a blanket. And the medical provider said, man, your temperature is 101 and your vitamin is elevated. We cannot do anything for you here. We need to go to the emergency room now. So then I'm saying, what is really happening here? And I'm shivering, freezing, and I can't quite get my thoughts together. So they're loaded my girlfriend. Jessica has blankets in her car, and she's putting blankets on me, and we hit the ER. Ooh, and I want to go. But we didn't have a choice. So they gave me some Tylenol at the urgent care. My temperature's not really breaking. And I'm feeling fuzzy and nauseous. So I get to emergency. They put me in a room really, really quickly. They take my vitals, they take my temperature, I'm wrapped in the blanket. And while they're taking my temperature is spiking. And then things start moving really, really fast. I mean, they're saying, man, we need to hold our really feel because we need this fluid going quickly. Then the other hand, somebody's sticking me, taking blood cultures, and I'm saying, why is stuff moving so fast? I'm looking up, I see the bag of fluid hanging, and it says lactic acid and acid. And I see the other bag, I asked them what the other bag is, and they say, those are antibiotics. I said, wait, this antibiotics, lactic acid, blood cultures, I'm saying, that's it. And they said, ma'am, this is real, because we need this food is going really quickly. And I'm saying, wait a minute. And they're also saying, and we need to take these blankets off because their temperature is 100. So free. And I was going, no, don't say my blankets are not free. So I stayed in the emergency room for almost a day waiting for a bed. And I'm so thankful that I have my medical friends who come to visit me, and they know the questions to ask and they know the things to recommend to make sure that are happening in order for me to get better. And I'm wondering, how in the world am I septic? I am super healthy. I walk, I run, I eat well, I pray, I have good mental health. And I'm saying, and they said that I may have a bladder infection. I'm saying all this on a bladder infection? So I stayed in the hospital for 4 full days. And I am weak during most of it. I'm a little confused about the fever is high. It finally breaks, but like after 3 days, it breaks. And I'm exhausted. I feel like I've been in a fight. And they never actually told me while I was in the hospital that I was septic, but it was on my discharge papers that I was septic. And so even like 3, 4 weeks later, I'm not really able to resume my normal activity. And it just baffles me. This sepsis thing is really, really serious. And so then I started thinking, obviously, if I'd gone to ER sooner, then I should have gotten treated sooner. And I started to feel, it's like it's a little unfair of me because the medical providers are now having to rush to take care of me because I decided I wasn't going to take care as soon as maybe I should. And so people really need to be taught about sepsis and the symptoms because I associated fever with a cold, and I didn't have a cold. So I didn't associate fever with an infection. I didn't know what to do. So people really need to be taught the symptoms and taught when you feel this way, go get care immediately.
Okay, thank you so much. This is wonderful. At this time, I want to open the floor. There you go. I got it. You guys can. I'm going to open the floor for questions. Just to, if there are any questions, if you could just repeat the questions so that the attendees at the remote sites know what is being asked.
I think so.
Yeah, please come
Please
on.
get some questions.
I don't have any written and sent in yet, but are there any questions from the floor?
So since there are people here from other sites and from other hospitals like Grady, maybe we can ask you how you're implementing a code sepsis or a sepsis protocol at your site. So I'm going to ask my colleague Mary to tell us, and then we're going to share what you say, Mary. How are you doing with sepsis at your site? You're a sepsis coordinator.
We're in the process. Wendy is here with me as rapid response team, and we're in the process of trying to fully man that team right now. She's probably the only full-time rapid response person. We have the support of administration and the support of the ICU directors and maybe answers. We have staffing challenges for the ICU, so we're trying to kind of pick the people very carefully that are on rapid response.
So one of our representatives here from Atlanta Medical Center is sharing with us that they are defining a rapid response team response for sepsis, and that's a growing perspective. Right now, you don't have a sepsis protocol per se, but as you're growing your identification methodology with rapid response, that's going to be occurring over time. Do you have anything that you think that you could say to give them some advice?
Yeah, be patient.
But
you know that.
Order sets, and if you do have protocols, it's the education piece and then the support of the staff.
Yeah. Yeah. And it's taken us a year.
And we looked at it, I think we were all looking at sepsis before a year, but now we have this very organized approach, but the implementation of it is difficult. And I'm going to say from my advice, and Sharika may have something different, I want to be sure she says something, but my advice would be start small. Because if you roll out to the ICU and all the inpatients and the ECC or the ER at the same time, it's going to be so difficult. But if you do it in a small framework like a plan, study, do, act, so you're doing rapid cycle change, that actually can be really helpful. And of course, this is right up Sharika's alley.
I totally agree with that. And our rapid response team, we could definitely not do it without them. So we need them on board early on and have them active and engaged and educated on the process, because they'll have to educate some of your doctors and some of your nurses too. So you definitely want to make sure that they're educated and engaged. That's my advice. Any questions?
No questions? No questions.
Okay. Any other comments, questions?
I forgot one thing in my
Yes.
presentation. I wanted to talk about the pharmacy and how they have stepped up to the plate. So when the docs utilize or provider utilize the 3-hour order set, and that page goes to their charge pharmacist phone, they have 15 minutes to verify and get either verified, and if it's available in that Pyxis, call that unit and let them know that it's been verified, or they tube it up and they call and say it's on the way. So I think that having them involved and engaged in that process was very instrumental, and it will be instrumental in getting the patients the time of care that they need. But also, one other thing that they were able to do is they could auto override for the dose adjustments. So before this, they would have to call the doctor, wait for the doctor to call them back, and then they would discuss, what to do with the antibiotic if the patient was a renal patient, or maybe their creatinine and BUN were not within the range that they needed it to be in. But now they have it where just for the sepsis order, they can auto adjust and just put in a note. I think it's just a progress note. Put in a progress note letting them know why they made the auto adjustment for the patient. So again, timely care right there at the patient because of their involvement in our community. So thank you.
And just to add to that, I think it's probably a good thing to say that I think Dr. Polito's wisdom here in working with Dr. Chitel, I always have trouble saying her last name, so Dr. Chitel Kandaya from our infectious disease group, they actually made in the sepsis order set these just small little bars that say GU, GI, respiratory, so that even a young doctor in training just clicks onto that and they get in a column fashion the antibiotics to choose. So it's become very simplified. And that's part of the strategy, is to take all this complexity and make it as simple as possible. So did you want to say anything else about that?
No,
It was a great work.
that's some of the challenge that we have in American gynecologists, is some of our residents and our physicians don't want to use the order set. They want to use an individual, they pick and they pick apart the order set and order it individually, and then we miss out on something.
Right.
So, and then, depending on the patient's history, which all of ours have to go on, they don't want to give the fluids because they're looking at, their heart history or their renal history, and they don't want to give the fluids.
Well, I want to be sure you know, it's not so easy for rapid response either. So what I basically say is, when you get that sepsis alert, run to the bedside, get there really quickly, so you can go ahead and look at that patient, make some decision, and at least start with that 500 ml fluid bolus. From all the data from everywhere in the United States that has robust programs that have been in place for a long time, and our own ED chief has said when they were so worried about doing fluids, they have not had one case of volume overload based on small, like 500 mLs is not going to cause the patient to go into volume overload. And I know Dr. Polito has something to say.
Oh, yeah. I'm just echoing what Barbara already said. There is evidence to support the utilization of fluid bolus in septic patients with heart failure and/or end-stage renal disease. So there's a Kaiser cohort from California that's published, so that may be a reference to provide to your physicians and your trainees as evidence that this is safe practice. And even more so, those patients did better when they received fluids as opposed to being harmed.
Dr. Polito, can you just address about having a physician champion? That's part of what you're doing, is this physician championship.
Oh,
They may not have that.
Yeah, that's another good point. So having really an executive physician sponsor, so our chief medical officer, who is also functioning as our chief quality officer right now, is the one who initially asked for a sepsis committee to be created for the hospital. So it came from the top down that this was something that's important for all of us to engage in, which we all readily signed up for because we agree with him. So if you don't have executive sponsorship or hospital leadership sponsorship from a medical staff standpoint, that may be an area to look to increase engagement.
Well, thank you very much. I think we all can agree that it definitely takes a village and that we all leave here pretty inspired to go back to our places and try to make this work. So I'm going to go ahead and close this meeting for today.